Michael Murphy, and you are, how do you introduce yourself?
I'm Michael Murphy. I'm the executive director and co-founder of Mass Design Group.
And Mass Design Group does a broad range of design work.
Yeah, so we're an organization that works, across typologies, but we're a mission-driven organization committed to finding architecture that fights for human dignity, social justice, and creating places that help us heal as individuals across spectrums, across typologies.
Which, of course, is a very important mission as it relates to design for dementia. What do you see as the biggest challenge of implementing that mission for housing for older people or for people with dementia or any group that needs that kind of social justice and dignity that you talk about?
Yeah, I think one of the biggest challenges, as we're seeing, especially with the coronavirus pandemic, is that it's affecting elderly people the most significantly, and especially in nursing homes, where rates of institutionalized injury and loss of life, as well as infection, are the highest. And I think that really should kind of shake us awake a little bit and reveal that there are significant problems in the way in which we're designing for the care of aging, the care of our elderly, the care of our elders, and in particular the kind of spaces in which we are surrendering them to in our society. One could argue that to look at our social order, you could look at not only prisons but also our nursing homes, our institutions, to see the kind of values and priorities that we project as a society, as a nation, and you can compare those across other nations to see how they take care of their own. And I think in the U.S. it's pretty evident that we have a lot of work to be done.
What do you feel is the direction that is needed to overcome what I would call the institutionalization problem? You mentioned prisons, you mentioned housing for older people. We could also talk about other institutions.
Yeah, I mean, I think, we like to think, we often have found to talk about institutions as really the architecture of the state. I mean, they really represent the values and priorities of the state. And so the institutions that serve primarily the elderly, those with dementia, those with aging in place, those that have greater needs and need of assistance, it's pretty evident that, as I said before, these spaces have huge needs and should be rethought. I think one of the greatest problems is that we are thinking about this problem at the scale of the problem, like at the scale of how many people we need to serve, as opposed to thinking about it as the service to the individual. So when we design for dignity, you're designing for the unique challenges that each individual might both deserves and needs. And of course, no two individuals are alike in the way in which they age and the challenges they face in their aging. Aging in place with wraparound supportive services tries to address some of those unique and individualized challenges in the same way that intergenerational living, family members taking care of their parents and grandparents also addresses individual needs and unique scenarios. But once we institutionalize that problem, it becomes a scale problem. It becomes how many bodies we can fit in how many rooms with the smallest amount of space, and it becomes a commodity problem instead of a dignity problem. And that intersection has always challenged the institutions. I wouldn't say it's unique to the United States. It's the challenge of the architecture of institutions. But I think it's particularly depressing. It's particularly insulting. It's particularly scary to think that so many will suffer under kind of conditions that are so undignified in their later years.
is that a design problem or is that a business problem? I mean, is it the business of care that's the problem, or is it the designers who just should really be focusing a little bit more on the individual? There's a phrase that says once you've met someone with dementia, you've met one person with dementia, not a person, not a class of people. So that's what you're really saying, which is to have individualized, person-centered care, you need to have a different design setting.
Yeah, I think that's correct. And I think it's both a business and a design problem. They are interrelated. Certainly the business models trying to address caring for the elderly, caring for those with dementia, have their own significant challenges based on the funding that they receive. Of course, those are other challenges we have to address as a society, but that doesn't mean it's not a design problem. I mean, it's a significant design problem because we're putting people in homes, physical spaces where they have to be protected, cared for, empowered as best as they can, and also handled with care. And the physical environment around them is a fundamental, or could be a fundamental asset in the delivery of that care. The inverse is also true, that not thinking about the design as a part of that process kind of surrenders the inhabitants to suffer into unthoughtful conditions or spaces that have not really been considered for the needs that they have. And that's a real lost opportunity, but also potentially a real liability.
If you were leading the design team for a project like we're talking about, whether it's for elders or elders with dementia, what are the criteria that you would put forth to overcome the problem right away, to say to the team, these are the principles that we've got to work on and work towards, design principles?
Well, we often, the way that we often begin is to say that every building has a mission, has a core idea, has to aim towards, a kind of North Star. And that mission is often aligned with, not identical to, but aligned with the mission of the organization that the building is serving. So if that entity is serving people with dementia, we would ask, what's their aspirational ideal and how does the building help amplify that ideal? If it's assisted living with dementia, if it's intergenerational living, if it's having a aging in place scenario, which attends to some people with dementia. I mean, there's all different models, business models and organizational models that different service providers might have as the strategy to protect and serve in the best way this particular group of people or individuals. And of course, every condition, be it a city or suburban or rural condition, and every country has slightly different scenarios as well. So no two are alike. And I think that's kind of one of the big challenges, but also one of the big opportunities, that each condition, each context, each group of people, each organization requires a different design and a different manifestation of those ideals in physical space. That is not to say that there aren't consistent strategies that design can address throughout institutional settings. And some of those lessons have been hard learned over the course of the last couple of decades. I'll just point to one. I think this is consistent with hospitals, certainly incarceration facilities, definitely nursing homes, even one could argue large-scale housing, that the hallway, that space of the kind of conduit between rooms, the double-loaded corridor, is consistently a problematic space. It's consistently challenged. It leads to a feeling of institutionalization. It's hard to manage for airflow and airborne transmission, as we're seeing now today with COVID. It's often the place, because of its being undesigned or designed for multiple uses, it becomes a kind of spillover space that absorbs a lot of problems of the institution. So we've consistently argued to remove the double-loaded corridor as much as we can from most spaces, and I think it's a consistent problem in as I said, in housing, hospitals, nursing homes. So that's one very, very specific strategy. Remove the double-loaded corridor, open spaces up to light and air, give everybody an individualized experience into their own space, create cues and strategies to create diversity of spaces inside that they could own and feel like they're not just another cog in the wheel of the institution. Those are all design strategies of creating uniqueness and difference, identifiable environments, dignity, individualization, identity. Those are all things that can be developed and amplified by, I think, the way in which we treat the space.
So it's really turning circulation space, as it's called, into a place that people can find their way and provide wayfinding as well as individuality. So but that's a key in the institution to change that element in design, which breaks down the institution, the institutional qualities. Does that also increase the scale, or reduce the scale of the project?
Yeah, I think I think that's a really good point that you said. I mean, that circulation space is still a place, and we have to treat it like a place. And the scale problem is that, and we've learned this the hard way through large-scale institutional buildings, that there's thresholds of management of communities. You can't just have thousands of people in a hospital. Different infections might emerge. You have to have smaller units of smaller care paradigms and treatment facilities. We've seen this over and over again, and I think it's the same problem in the care of the elderly. The challenge we have, is to figure out how we have unique and small-sized, individualized care programs inside of a system which has massive need and a scale of need that's overwhelming and hard to fathom. And that is the intersection of the state with the service. I think that's, again, I go back to that original point. And that intersectional point is the building itself, is the institution. So how we design it helps also reinforce those aspirations. And so there's been examples of where the groupings of people, be it in a hospital, the Nightingale ward, for example, having a limitation of no more than 35 people in a ward, or no fewer than 15 or so, is an example of a kind of parametrics of the control of a group. The same is the case in the care of the elderly. I mean, we would want to create, and in the work that we've started to design, create unique, what we call neighborhoods or villages inside of the building, so that there's a care community that's taking care of each other, instead of just a long hallway with an infinite number of people that are uncountable and undifferentiated.
Yes. Undifferentiated. So you mentioned the Nightingale ward. Did Florence Nightingale in the last century have all the answers, or at least the direction? What did she contribute that you felt was positive?
I think Florence Nightingale is one of the great architectural geniuses of our contemporary society. I mean, she really, not being an architect, probably did more to change architecture and the built environment than many others. And she did it because through the lens of guidelines, her notes on nursing, notes on hospitals, she did it through a kind of clear belief that a care paradigm or a program of care is directly related to the space of care. That the two are not differentiable. They're not able to be separated. The two are integrated. In other words, for patients to get healthier, to reduce infection, they needed airflow, they needed a certain amount of space, a certain amount of nursing and staff, of caregivers, and that if it became too many people and too few staff, the problem would tip over. If it became too few patients and too many caregivers, another problem would emerge. That there was a kind of parametric, living, organic, dynamic relationship between staff, space, and service. And that, I think, is a really important lesson that we're still trying to wrestle with today. A lot of folks want to, a lot of policy wants to separate the building, the space from the service. Assuming that the problem is fully about training caregivers or having a good policy in terms of the program, and that any space could handle that. And I think Florence Nightingale in the 1860s was saying that that's not the case. And I think we should take that lesson very seriously. And she asked the question from multiple dimensions. She asked it, how do we improve the conditions of the physical spaces that are serving, especially the most disenfranchised and the poor. In this case, the kind of public hospital that's emerging in the mid 19th century. She also asked it from policy and scale. How do we create guidelines that improve the overall policies of the nation state so that there's consistency in measurement and in improvement in overall outcomes, i.e. saving lives and improvement in health. And she also dug deep into creating the capacity of an entire profession, the nurses, this whole idea that we have to train and invest in caregivers and create an entire army of caregivers to meet the need between, let's say, the theory of medicine and the treatment of care from the family and the home. That there's somewhere in between. There's a whole class or a whole profession of nurses that could provide this service.
She actually, so she personified that vision. By the way, Maria Montessori, also not an architect, but somebody who had a vision for education, also had major impact on physical design. Correct. Yeah. Among the things that Montessori did was that schools had walls painted black up to about 4 feet. So the kids, when they put their hands on the wall, the finger marks wouldn't show. So she said, we can't have kids walking down a long hallway with black walls above their heads. So let's get rid of that. She also made chairs where their feet could hit the ground rather than hanging out on big chairs. So she really understood the environment as well. These two visionaries, one in healthcare and one in education, Nightingale and Montessori, both personified what you're talking about the vision. Let me switch for one sec to a question about, you've done a lot of work over in Africa and with different cultures. Would you say that that work has influenced or influences your way of thinking about healthcare and institutions and the process of design?
Well, I mean, yeah, absolutely. The work that we did early on with the organization Partners in Health and the Rwanda Ministry of Health, and then into the Liberian Ministry of Health. Of course, it influences us still today, and I think it's some of the ways in which it's influenced our thinking more broadly about the role of architecture in improving people's lives and in helping us heal from conditions that we might be faced with contextually, culturally, socially, politically, or physically, are relevant, not just in Rwanda or in Liberia, but they're relevant discussions all over the world today. What we learned in our first project in Rwanda, in this case, it's called the Butaro Hospital, and it was a new hospital for the government, also with support from the organization Partners in Health, and they had enough money to build a building, but not enough to import a large mechanical airflow system that could be maintained and have a whole maintenance team, have the expertise to control it and manage it. The whole idea that buildings required large-scale mechanical ventilation systems, we had to kind of throw out that idea for a hospital, which kind of flies in the face of the way hospitals are designed in the United States. But it also opened up and kind of liberated us from the, let's say, hegemony of the mechanical or technocratic systems of our institutions, and said, well, if we go back to the way that institutions should be focused on, from Nightingale, from Alvar Aalto, from others, that it's the individual life, it's the dignity of the experience, it's getting healthier when you enter a hospital, it completely transformed the way we thought about what the hospital could be and should be. And it changed the way I understand institutions all over the world. And now I think we're learning from that hospital and saying we should be, in the middle of the COVID epidemic, our buildings that don't have open air, don't have single-loaded corridors, don't have windows, are the most dangerous places for the transmission of epidemics.
Right. So these are global lessons you learned from these other cultures.
These are absolutely global lessons because they're institutions. Because institutions consistently are trying to wrestle with how do we serve the population, directly with the limited resources and the scale of problems that we have. And designing specifically for a context and specifically for a population, the kind of uniqueness of that strategy revealed to us that actually you could solve not only challenges locally, and they could be specific and identifiable, but they also help us solve problems at scale, institutional problems, that we should rethink hospitals altogether, that we should reconsider schools to be learning environments based on pedagogical frameworks, not just based on how many kids you put in a classroom, that we should rethink care for the elderly, to have unique places for aging and assisted living instead of a kind of imprisonment of institutionalization. Yeah, these are all lessons I think we can learn, and the built environment is at the intersection of them. It's not going to solve all the problems, but you're not going to solve those service problems without addressing the built environment.
That is a great sort of ending to the message that I think you've so well presented. But I would like to ask one last question, which is if I asked you to design a poster that would go up in every developer, operator, designer, state or office about designing for dementia or designing the way you think it ought to be done, what would the poster say? What would be on that poster?
Well, I like that question. My friend John Kerry says this really well. He says if justice is to law and medicine is to health, then dignity is to design. Sorry, let me say that again. My friend John Kerry says this really well. If health is to medicine and justice is to law, then dignity is to design. And I think that really kind of exemplifies what we're talking about, that this is an essential, fundamental service that design, and we put the built environment within that broader overarching category of design, is providing to us every single day. It's either giving us spaces of dignity or spaces of indignity. It's not neutral. It's one or the other. And it's our kind of responsibility to name those spaces of indignity and to change them, and then to advocate and fight for spaces of dignity, spaces that represent and fight for your individual beliefs and lifeways and values as an individual, that sees you as a human being. That is ultimately what I think design does, and what institutionalization removes or takes away. So we want to, it's always a battle for this, but it is a crucial and fundamental service, and it, in my mind, is a right that we are not advocating for enough.
Michael, I hope you win your battle, because it's a battle that all of us need to be part of, and the fight for dignity and to overcome the indignities that we all experience and everybody in healthcare wants to overcome or needs to overcome. So thank you very much for participating in this.
Thank you so much, John. Great to talk with you. Thanks for your questions.